to record and provide a transcription of this session unless anybody wishes to object to it. So if you would like to object to this recording, please go on mic and share that objection with us, and then we won't do it. All right. Okay, so some more updates, and I know you're still waiting for some more deliverables. I have, after today, I have 2 working days left, and I am going to get these deliverables to you either in finalized form or a draft for last minute comment. For instance, we've got the draft for the IROS guidance to lift the PA written. Carolyn, I need to get that to you and get your blessing on it. Are you in the office on Monday by chance?
I am not. Today is my last day until after the holidays.
Okay, then I am going to try to get it to you after this meeting. And if you have some open time later this afternoon, or if you could find a little time for me, then we will try to make that work.
Okay.
All right, thank you. Okay, so the other things that we have going on is I'm going to forward you folks a brief spreadsheet that will have the billing code changes for the new services that we were talking about having opened up for 1/1/25. The public notice will be going out for those. That is to open the peer support service for the SMI population. So that public notice will be going out before the end of December. We've sent a preliminary draft of the state plan amendment for peer support to CMS so we can kick off our technical assistance discussions with them before finalizing everything. The draft was formulated largely off of all of the rule revision language that many of you had worked with Phil Bradley on before he retired from the state, or you've subsequently worked with, I think, Evelyn, have you been leading the rule revision discussions over the past year?
Sorry, I thought I undid the mute and then I redid the mute. So,
okay. Yeah.
So I'm working with our new staff attorney, Lee Solbeck, on the rule revisions. So we've been going over all of the feedback that was previously developed internally to go with the Office of Legislative Services rulemaking manual to go over internally to make sure that we're following the draft writing style guidance and any updated legal questions from our legal team. So that's where those are still at. We're wrapping those up and trying to get the first package into its final version so we can share it out with all of the CMHCs. At the same time, we bring it forward to look at doing the MCAC review, as well as having the initial proposal start its final official formal process for rulemaking.
Okay, great. So the peer support language, it will still, the rates will go in at parity with the SUD rates. And I know that was not something that everybody wanted. We wanted to match it up with the current functional support services, but we were not able to achieve that in working with Medicaid, largely because of legislative intent that was expressed during the last budget cycle. We're obviously coming up to a new budget cycle. I don't know what will happen with that impact with those discussions, but we will get that out to you folks for the codes and the rates. Kelly, go ahead.
Diana, the public notice, is it actually just sort of going out on the page on the DHHS site? So if people want to see it, that's where they'll go? Because like in the MAC every month, they say, if you want to see any of the state's public notices, you have to go to this link.
So I wouldn't envision that changing. It'll go through the whole Medicaid state plan team.
Thank you.
Don, Tierney, Jody, and Sarah. I haven't heard any discussions of doing it differently than how they normally do it. If that's helpful. Okay, go ahead.
Have there
Jen,
been any
sorry.
discussions about whether or not this impacts the case rates that the mental health centers have? Since you're introducing a new code or codes uh, with different rates?
So the fiscal impact for the peer was already incorporated into the rates. We anticipated, based on our discussions here, we anticipated low uptake for the period through June 30th at least. As you folks may recall, we had a discussion about that probably a couple months ago, and with the rates being approximately $2 lower than what your functional support services rates are, my recollection was that we felt that there would be collectively, the sort of consensus was that there would be low uptake. So they did add a little bit of money into the MCO rates for the CMHCs already for that. The public notice will speak to the impact for fee-for-service beneficiaries. And again, that's fairly small.
If HEM 408 has not yet been updated, or it's going to be consolidated with another rule, where will the instructions or rule for documentation reside?
Evelyn, do you know off the top of your head if you folks are planning to add it into I think what we're calling it like other additional services? I believe we're not going to continue to use them and bundle them as IROS. Is that correct? If you can't answer right now, that's, you can take that back and get back to the centers at a later time. I won't
Right,
be
so
able to, obviously.
Right. If we're going to be implementing something new on 1/1, we would need to have the instructions on what's required in order to do so.
So, and I think, Diana, that's where we can talk offline between your team and Lise. Lise is fully happy to support developing any guidance out to the CMHCs needed for 1/1, because we cannot affect rulemaking changes by 1/1/25.
Mhm.
So as we have those needs, just let us know how we can support, and we'll work to get the guidance out there for them so they have what they need.
We're all going to want some formal document,
Yeah.
right? That gives us guidance, that also gives us the authority to do that. If you're not going to change the rule ahead of time, or at least make it coincide, then we need something else that
Right.
allows us to do it.
Right.
I'm also a little confused on how this got into the rates and the actuaries with Milliman and passed through into our cap rates. For something, I don't recall any of that being discussed in any of our conversations about the rate setting.
Chris, I believe what they did is they took a very small percentage of what we have for functional support services utilization and bumped that slightly, based on the fact that it would only affect that 6-month period. And the majority of the centers said they wouldn't switch their provision of services. They would stay with fee-for-service. The functional support services. So I
was
think they
this
just
done
did a
as
nominal change.
reset? Was this a reset rate? Because these decisions have only been made in the past month, and I don't know when that discussion would have happened in terms of a reset or the setting of rates for the final 6 months here.
So whatever the latest conversations were for the amendment that is going forward with GNC, it was incorporated into those actuarial predictions. So it was the Milliman work, and I don't know to what depth of the discussion they went into this particular detail. But I do know that we incorporated a small amount for it.
Good.
Okay, so I'm putting in the note there, formal guidance document for that pending admin rule development. Okay. All right, so I'll send the code list to include the modifiers that are going to apply for the community reentry demonstration. So the pre-release services are under the demonstration, so they will carry a special modifier so that we can separately grab, if you will, the utilization associated with the pre-entry services. The adult community reentry demonstration team leads were here last week, and we were going to try to bring them together with the MCOs and you folks today, but we weren't able to get that worked out for today. But you'll get the codes for those. The CCBHCs will get the codes to include also the SUD targeted case management. Do all the CMHCs want that? Because you're not all providing services to the SUD primary population. So I wasn't planning to send that to all of those, just the ones that are going to be CCBHCs.
Given what we've got going on with Southeastern, I would like those codes, please.
Yeah, and
Okay.
when we do have discrete substance use disorder services, this is Lisa from Riverbend, so we would like that as well.
Right, we do have some primary SUD at Seacoast, so we would like it as well. And also, again, would need the 408 or equivalent formal documentation requirements.
So they won't
Or are they
be,
513? Are they HEW
they'll be
513?
513.
So
Yeah.
whatever, we need formal guidance on the documentation requirements and know where to get that.
Seacoast, Nashua. I think that's
Diana,
my
just send it to us all. Those who don't need to read
Okay.
it won't, believe me.
Okay, thank you. Directed payment, Patrick's shared let me see, the first contact definition. Put this over here so I can see it a little bit better. My apologies, sometimes it's hard to navigate the 3 screens. Okay, the first contact, and we're working out a method to do the documentation retro to September 1st. The first contact definition we have includes capturing the data for individuals seeking services who are not yet and might not become patients, capturing this distinct date for the first contact. A first contact for routine services must be a patient or a legal representative. A risk management / triage could be completed at first contact. And that's because some of you are and aren't, depending on if you're a CCBHC or if that's just your practice. A routine care walk-in would be considered first contact and initial service. I think he also shared your general position is that you would not want to have to send first contact date for patients that are not opened. So Patrick, I had a question about that. I'm just put it out there for folks. When saying that, is it that they are not open or that they've received an intake but were found ineligible?
The centers have a definition of whether or not a case is open. Really, it has to do with acquiring necessary elements to be able to submit data to you all saying this is a new patient potentially at the center. So the answer to your question would be the centers will be determining whether or not the people have been opened, and if they're opened, they would go to you. It's the same process we've had for a very, very long time. It has to do with creating an episode of care for the client, right?
Mhm.
And you demand an episode record, and we create an episode record. The person becomes open, and you get the data.
So
Does that answer your question, or?
It does. I do know when talking with our quality team, that we do have interest in being able to measure if the timely access new payment is really creating improved access. So being able to
Yeah.
make the payments for those that did succeed in having the intake within the 30 days tells us the positives, if you will, but it doesn't tell us the number of cases that didn't end up getting an
But-
intake within the
but-
30 days.
Right, but Phoenix is not designed to be able to capture data on pre-admission people, right? So on people that we don't even have data on yet. That's the challenge. I mean, if you're
Right. So if we didn't use Phoenix for that, you folks are capturing it somewhere, right? Even if they don't become patients, I believe when we had talked
yeah,
previously.
what we are talking about is giving you pretty much all the data that we're capturing. I mean, that the definition is something that I'm sorry, Diana, I'm not sure where you're going. I mean, we get a lot of calls that would be calls where we don't have definitive information on the person. Is it a new person? Is it somebody that's calling back for the third time? Because they're not providing that level of detail. Therefore, it didn't make sense to include those because you'd have numbers that would not have validity or reliability, right? So we're saying at this point in time, we are relatively confident that the data is valid. So in other words, that we know that this person is a unique person and they exist, and that we can reliably report it across centers so that each center is reporting in a similar fashion. And to be able to get to that point, that's kind of how the definitions have come out the way they've come out, if that is helpful.
It is. So if first contact is made and it's being documented, I don't think we have a concern about that because you're capturing what we'll all agree is the first contact, right? But then it says that they won't send the first contact, you guys won't send the first contact date for patients that are not open. So if they're not open, they're not patients yet. So I get that. You're saying you don't want to send it, not you personally, but
Yeah.
we don't want to send the first contact if they're not opened, and they wouldn't be opened until they had their intake. Is that correct? Unless they receive like a crisis service, right?
If they receive crisis services, they'd be opened, is the second part of the question.
Yeah.
The first part of the question, and we'd have the data that would be able to meet those two criterion of reliability and validity. I've got a suggestion. I know that this is like a short meeting. So I do have a meeting. I believe Andrew can attend that meeting next Friday. And I know that we'll be looking at this. If you have another question, and I think I'm hearing another question. Is
So we
there,
want to be able to have the data that represents first contact, even if the person did not get their intake within 30 days.
yes,
You'll
you have,
you'll still get that.
you have
Yes.
That's what I
Right.
wanted. So I'm reading
Oh,
this and it
absolutely.
sounds like we wouldn't get it. So we
No,
will
I
be
think
able to
you're-
have the right nominator and denominator.
If
Great.
they're
Yes.
opened, you will get that, right?
Remember that, yeah, the other piece is that the data is actually getting renewed on a monthly basis. So what you're saying is you're worried about some kind of a delay, that would be compensated for in the way that the files are being submitted.
I'm not worried about the delay. It's what I'm sorry, I didn't see whose voice this was.
Heather,
Heather. So
Yeah.
Heather, when you say that we'll get it if they're opened, that means that we wouldn't get all of the first contacts if they didn't get opened.
That's correct.
you would not.
But
So-
why
get
would
people
you
we don't
want
have
that, I
data
guess
for.
is the question. Like you would have hundreds of patients that potentially called and never came to see us. I just don't
And-
know the value of that.
And that
I-
also might not be a patient. I mean, might not be a unique person. Sorry, Heather.
No, you're fine. Like you will see data if Joe Smith, called and we didn't see him for, 4 months, you'll still see that we didn't meet the mark, right? But not until he actually has the intake.
Okay, so we would be able to see the first contact, and then if they became a patient at all, like they came in for an intake or something like that, if they just never followed up with you guys at all, then we wouldn't see that. But if they did follow up and it was just past the 30 days, we would see that.
Yeah, at the point,
Correct.
Okay, that's very helpful. Thank you. So Chris, I'm sorry, I know you had your hand up there a second ago, and I'm reading your note right now.
Well, I had my hand up, but I didn't put in a note. I was just going to say what we ultimately came to is that you would get the data once we did the intake on the patient and admitted them into the agency. It would
Okay.
then come through the Phoenix.
Okay, all right, so we're just not gonna end up seeing whomever didn't actually connect for services eventually.
Correct.
And as the note in the chat says, that's consistent with a CCBHC measure.
Good, okay. That was super helpful for me. Thank you very much. And I'm sorry, Chris Drew is who had their hand up, but Chris, is it Kluke?
It is Kluke. Well done.
Yeah. Thank you. Had put that in the chat instead.
Too many
Okay,
Chris's.
that's all right. It's just like John's, right? And Mary's and, that type of stuff. Okay, so CMHCs and CCBHCs collectively support a time frame of 90 days for a clock to be reset. In terms of, is that speaking just to the timely access
it's,
directed payments?
it's speaking to when you would begin to count somebody as another potential instance. So the question had to do with, is it 90 days? Is it 120 days? Is it 360 days? And the centers, or is it 30 days? And the centers agreed that 90 days seemed like a good reset.
And is the 90 days the same reset that you would have in terms of if you were to do a new patient versus an existing patient E&M service?
No,
No, that's a little
no,
bit
2
different.
years. Yeah, I think it's 2 years is the reset for a new patient for E&M.
It's
Okay,
three.
so
Three,
I'm
I
sorry.
think. 3 years.
Oh, yeah, 3.
Yeah, this is really
Alright.
just if John Smith called us once, didn't come in, called us again, then we could reset that clock at 3 months. Right?
And they'd be eligible in the denominator of the directed payment.
Okay, so if we have it at the 90 days to reset, would the intake code that we would be looking at for documentation of the timely access still be the 90791 or 90792? I believe so. And then we have the 99200 series. Because sometimes you might have a person who gets their intake and sees the prescriber on the same day, right?
Mhm.
So we want to envision this 90-day target does not otherwise impact the use of the codes that you would normally use for the directed payments. Meaning right now you have the codes for the timely prescriber following intake, right? We have those codes identified. Nothing in going with the 90-day frames would change what those codes would be, right?
I don't believe so.
Okay.
Uh,
Just make it, I don't want to like solve one directed payment logic and then disrupt the other one necessarily. That's why I was asking that. Thank you.
Yeah.
Okay, so I think those were the last few outstanding. Now, for the retroactive to September 1st, you folks have all sort of been keeping your own records as to those items those instances where the timely access would have been successful, so you could get prepared to do the billing for that, correct?
I'm a little uncomfortable answering for everybody.
No, I'm just,
But
I'm
yeah,
opening it up. Sorry, thank you for that, Patrick.
yeah, okay, yeah.
Have you folks been like starting, some sort of are you going to pull a query out of your system, create a spreadsheet? Is
Yeah,
some report you're putting together, or?
Yeah, we just need to know what elements you need in that particular pull, right? Do you need patient ID, name? What do you need in there?
Okay. Can you, it would it will really expedite answering that question if you can share the data elements that you guys have already grabbed.
We, like I said, we have a meeting next Friday.
Oh, you're going to
and-
talk to Andrew about that. Okay.
And my hope is that we could collectively spend some time on that, if that works for you.
Yep. I won't be here, but that's okay. So Lorian, will you connect back up with Andrew to make sure you get invited into that meeting so we can get the documentation process ready for that? And Evelyn, you probably should be there as well.
So if you want to send me those contacts, I'll loop them right in, because I'm doing the meeting invite. Right.
Yeah, and I really shouldn't have spoken for BMHS. I mean, Evelyn and Carolyn, does that sound right to you?
Go ahead, yes, have me on the invite for the meeting, and if we need to reconsider appropriate representation in the meeting, we'll go from there.
Okay, thank you.
Thank you.
Okay, thank you on that. Just trying to figure out if there's other additional things that we need to deal with. The peer, one thing I did want to share about the peer support, and Evelyn, correct me if I am misunderstanding. I spoke with Evelyn and Carolyn, with Jeff Atwood, and we were planning to open up the peer support for adults only. Is that correct? It's not going to be for the SED population?
That's my understanding as well. Well, yeah.
Okay. So I just wanted to lift that up for folks. I don't believe we're writing it into the state plan with that specific limitation, at least not the current draft that we sent to CMS. Again, we expect changes to the approach and draft when we have the TA sessions with CMS. But as of right now, we weren't looking to add it for the youth population, just for the adults. I will share with you that we do have peer support services open for children under the Medicaid to school benefit package, which I know is not you folks, but I wanted you to at least have that awareness that it is open and available in the schools. Let me see, anything else I needed to try to close out questions with? The update to the mobile crisis services guidance. I've got a meeting. I'm going to try to get an hour together with a couple. What Brian Harvey's been meeting with Jeff Atwood a little bit. We need to sort of restructure that guidance based on the new state plan. So, for instance, I think I've shared with you folks several months ago that presumptive eligibility for CMH level of care will not be needed for Medicaid beneficiaries. It'll still be needed for non-Medicaid beneficiaries. That largely ties to the fact that under statute, the community mental health programs need to be able to provide crisis services, but there are limitations still in the rules. So we haven't, I think we still have to do presumptive eligibility for them. We there was some concern that Brian had shared that some individuals are receiving crisis services more than 30 days past the first crisis service that they had. So there's a lot of stabilization still happening with individuals past 30 days. We have a lot more flexibility if they're a Medicaid beneficiary for that. We have a lot less flexibility for that if they're not a Medicaid beneficiary, because we still have enforced rules on that front. So there might be something that, BMHS needs to look at for the non-Medicaid population on that front in the guidance. So Carolyn, that will be something that we'll have to take up with you as well as they're working to finalize guidance on that front. The intention was never to carry those forward past the 30-day episodes, right? It's just, I think it ended up happening in practice, and we didn't anticipate that in the guidance originally. So I can't speak to that because is the non-Medicaid side of our governance, if you will, in the department. So we are still working on those things. For now, the last guidance still controls, but we just don't need the presumptive eligibility for the Medicaid population now. And I think those are most of the outstanding things. Maggie, we will be giving an updated list of that DBH Medicaid initiatives. I provided to the Medicaid state plan team all of the ones that are like to be determined because we didn't get to them in 2024. And I don't know that we're going to be able to do some of the things we had on that initiatives list and in 2025, where it's a budget year. And currently, we're anticipating a very challenging budget cycle. Jay?
I just want to go back to the 30-day limit. So you're saying that that's not outlined in current rules and documentation, but that's what you want centers to limit it to?
No, it is talked about in the current guidance already. What I'm saying is the presumptive eligibility piece is like for the non-Medicaid population, since we don't have to worry about the Medicaid now, for the non-Medicaid population, right? The foundational policy is in the emergency services part of 426. I think it's 42609. And that speaks to 6 units, 5 episodes of care. And then back then in 2022, when we were working on that guidance, 21, 22, somewhere in there, there was some questions about what's an episode. And generally an episode is on that space, it was like each day or something like that. And we stretched it to like a 30-day window under that guidance. With the assumption that the presumptive eligibility would be able to move from presumptively eligible for CMH to actually eligible. So the person would get an intake and get that designation. Then it doesn't matter if it goes past 30 days. So that's really the key. Can we get the eligibility determined within that first 30 days? Then we don't need to worry about it going past 30 days.
Okay, thank you.
Yeah.
Diana, the other thing that I believe is outstanding is the codes and billing for crisis beds or a place to go or whatever we're calling different things. I don't think we still have that nailed down.
That's right. Those that has a TBD. So the current codes work. The rates, right? So if for example, in a crisis stable, the model that you're looking at for lakes, for example, more than if you have 2 people involved at all in that 24-hour period and they've provided more than 6 units, right, of service, you're past the 90 minutes, which means the per diem qualifies, right? And that is it's a very good rate. If you don't have more than 2 people that are involved on that date and you're providing crisis stabilization without the HT modifier being able to be used, it's, you know, the per diem rate there is what, $600 something a day, something like that. So those will stay in effect until the department takes up setting up specific rate setting for each center or whatever it's going to decide to do. So those have TBDs on it, because clearly they're not going to get to that work by January 1st. And we would have to do state plan amendment for the rate pages at least to do those. To stand up those new rates, we have to stand up the state plan changes on the rate side. And we did not do that in getting the ARPA compliant services state plan. We just said it would be based on the fee schedule. So when if they move to that, that's the process that they're going to have to go through.
Diana, okay, so I just want to check with Cheryl Farren and
Yeah, she's-
Sunshine, who are on with me, to
Yeah.
make sure we have those existing codes, because we're thinking we could potentially open January 15th, at least for some services. And I just want to make sure we're all set and we have the billing guidance to use what exists. Cheryl?
So I do have questions. Can you hear me? Because I know my camera wasn't working earlier.
And I can see you too.
Yeah, good. So with those codes, though, you require a master's level clinician to be rendering those services. And I didn't think that
for the HT, we're not going to need the master's level, because that was part of the work that we did with the crisis spa when we realized that we went back to RSA 330A, I think it is, and we saw the exemption in statute for certain entities. I kind of nicknamed it the CMHC and FQHC exemption, but it's for whomever can provide psychotherapy, can do a crisis assessment, and that ties well into our rules under HEM. So if you don't have a master's, but you have a bachelor's level who's enrolled in like a master's program, that would qualify under our rules to be able to provide psychotherapy.
But it was my understanding a place to go was supposed to be mostly peer support, not master's level clinicians.
They don't have to be
master's
masters.
interns.
So when you were talking about the masters, I was assuming you were talking about the HT.
Yeah, the HT requires a master's with a bachelor's level or a peer support. That requirement is master's level or master's level intern. It's not bachelor's level.
Yeah, so it will change. That's part of the updated guidance. It won't have to have a master's now to qualify for the HT billing. It will have to include, to qualify for the HT, it will have to include somebody who's capable of providing psychotherapy.
Right, but the only people that are capable in the state of New Hampshire of requiring that are master's level interns or master's level clinicians, not bachelor's level. And peer support doesn't qualify.
They don't have to be bachelor's interns if they were bachelor's enrolled in a master's.
But they're not. That's what I'm saying. The staff that's going to be there we were told, at least that I was told, that it was peer support, and peer support don't require any kind of bachelor's or master's level credentialing.
Right. But we had
and they can't do psychotherapy.
No, they don't have to have a crisis assessment under the SPA for the center. If they need one, then obviously they require one. But if they don't need one, you don't have to give that. But on the,
But the codes that you're directing us to use for this program require that. So that's why I'm questioning it.
Right, they're the existing codes and rates, but the qualifying language is going to change. That's what has to be updated based on the SPA. But we are changing that. That's one of the deliverables that we're trying to get done before the end of this year for folks. And I do know that your model is planning to, I think it's the Plymouth location. Are you guys still looking at Plymouth, by the way?
Yes.
Okay. Give me 1 second here.
Yeah, because there's no way peers are providing psychotherapy.
Right.
Yeah, no. And they're not, you don't have to provide something that a person doesn't need. I just want to make sure we're clear on that page. So hang on a second. Scrolling down a draft. Da, 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 da.
And we don't mean to take up everybody's time, Diana. If you want to do this offline on a conference call or something, I feel bad because, you know, we're getting into
Right.
weeds and what have
Yeah.
you.
Right.
Yeah, well, the update's gonna come for the guidance, and that's really gonna help drive it. And I think everybody has mobile crisis teams, and you might be thinking of, well, what are we gonna do in the future? What do we want to do in the future? Things like that. So if you were using, let's see, that's the intervention code, stabilization services. Okay, so S9485, S9484 is the 6 units, and then after that, so here it says the 2-person response or 1-person response with master level, bachelor level, or less than bachelor level. So those are some of the languages that we're gonna clean up. And under the S9485, that is the crisis intervention. But one of the interventions that are covered under the state plan is stabilization. So that might be one of those places where we'll say the language cleanup might look like, if it's for an intervention, then you have to have somebody that's capable of providing the crisis assessment, meaning in terms of like the psychotherapy level. Versus part of the language cleanup might be that if it is for stabilization, these qualifications, right? So we'll get that drafted, and I'm sure that we will host sessions to work on that language as well. But that's kind of what I'm saying. This has to change a lot because we opened up a lot more possibility once we did the state plan. We opened up a lot more flexibility.
Okay, well, until that's opened up, we really can't bill for it, so.
Under the changes, right? That's why it's
Yeah.
part of and Maggie, I'll if I can squeeze that in, but right now, honestly, most of the delay in the deliverables is because I do spend a lot of time in meetings. So right now I'd like to get the drafts of things at least out the door. And it could be that we send them out in non-draft version and we're like, this is the updated version as of this date. And then if it's not perfect and we need to make more changes, the department will still be able to update that again. We don't have to get locked into it permanently, but I understand we need to put something in writing. So all of you folks have that authority to do the work that way. So if my goal is to make sure we get the documents out before the end of the year, and that if they're not perfect, that we can revise them after that. Carolyn,
Absolutely.
this
We
is,
would still appreciate anything in writing, that's for sure.
you guys have been so patient.
Diana?
And go ahead. Steve.
Before we move on, CLM would like to be in those weeds with lakes. Our crisis center seems to be in limbo because nobody can give us rates, but I'd like to be in that conversation about the guidance.
Yeah. And Steve, the CLM model that you guys are looking at, you would be setting it up as an actual center. And I know it's nomenclature, but we have crisis stabilization services. That's one section of the state plan. And then we have crisis stabilization centers, which is another part. And then we've got the whole mobile crisis team model for the ARPA compliance piece of it, right? But the one Lakes is putting in, if it's primarily peer, it won't meet the definition of the crisis stabilization center under the state plan. But that doesn't limit it from providing crisis stabilization services in a physical location for whatever hours of operation, right? I believe CLM is looking at a model that would meet the definition of the crisis stabilization center. And if that was the case, the per diem rate would work, right? The $1,200 something dollars. It's more than that right now. This is an old version. But that would be able to be billed even under the existing language.
My
If-
point is, Diane, I guess I want to be in the mix because this is confusing and I'm not sure how it's going to apply or what our final model will be.
Right. I have given my own personal recommendations on how to approach it. Or I will leave those behind with the Medicaid folks. Again, I don't know when they're going to be able to help take up the rate changes. Because we are lifting all of this off for 1/1, and then we'll have to try to visit those rates for the stabilization center model specifically, and look at the funding for it as well. So on the Medicaid side, at least. Do we still have Carolyn here? I think we lost her. Okay. All right, so
I'm here. Can you hear me?
Yep.
Oh, okay.
Yes.
Anybody who's been on with me the last few days knows my microphone and keeps going in and out, but I'm here. Oh, now I can't hear you. Can everybody else hear Diana?
Okay, that's because,
Oh.
and I don't really know how this happened. Somehow I must have clicked mute or I touched my ear. The little controls are very sensitive and they can mute me and I don't even realize it. I try not to touch those. Anyways, what I was going to say is on the mobile crisis, it's not unusual for us if we're going to do a billing guidance like under this, less than ideal timeliness approaches. So like, for instance, when we had to when we had to develop a lot of guidance to wedge between what was happening because of the pandemic crisis versus what the rules called for. I mean, the department was just like churning out as much billing guidance as possible or practice guidance as possible to sort of thread the needle between what the rules require versus what the pandemic needed, right? So on this mobile crisis changes that we're talking about, we'll update the billing guidance. And what I was suggesting is that internally, at least, we said, okay, this is about as good as we can get it right now. Let's release it. We can still update it in having these conversations with the CMHCs, like if January is like, oh, this isn't going to work, if we need to make more changes, you can still update it again after that. So it's not like we can only do one update a year. We can be more responsive than that. And I'm just sharing that with you because I don't know if you've had to do any guidance changes to sort of thread that needle between rule and practice this year, because you've joined us, in May? Is that when yeah. So that's the approach that I would suggest. And we won't let the perfect stand. What is the expression? Don't let the perfect
Be the enemy of good.
there we go. Thank you. So that's what I was suggesting we take for an approach. And then the centers, so at least in January, I think there should be some regrouping on that. And right now the Medicaid team has not, this has been on the to-do list for a long time. And they just have not had the bandwidth to take up the crisis stabilization center discussion. So, on the Cypress site, they were waiting for answers as well. I did provide a recommendation for that. The actual updated billing guidance might help the Cypress Center as well, because Cypress does bill S9485. And with our new SPA, you probably have more flexibility to bill it more under this framework instead. But those are conversations that we need DMS really at the table for. And again, with all the other stuff going on, they have not had the ability to get that done yet. It's not for lack of trying. So, let's see, update the DBH. And I'm gonna, Maggie, when I update that list, I'm gonna take out the internal extra steps that we have to work with, like the MMIS rows, the rule rows, things like that, and just have it be the high topics and like where we're at with those things. Just because I think it's for some people who aren't familiar with those internal processes, and then they're looking at it and it's like, well, what's this? What's that? And you guys just need a quick update to know what's still on the to-do list. So,
Okay.
okay. All right. Anything else that I could try to answer for right now? Chris?
Yeah, sorry, I wasn't here last Friday and I know we're short on time today, but will there be another meeting or another venue to work on operationalizing the community reentry?
I will leave that to the Carolyn Richards. She knows that we wanted to do that. Did you, Chris, you folks still want to have that with the MCOs so you get insight into how the MCOs are approaching it, and they will get insight from you folks. But what I can tell you right now is no one is going to be expected to need to provide a pre-release service on January 1st. So they're looking at January 1st as the time where DOC will start screening those individuals to trigger the reporting to the MCO, and the person getting opened up, the MCO will get that first notification. And then based on if the individual has been identified by DOC as having SMI or a need of services because of SUD, the MCO will be doing the outreach to the applicable provider system. So for the SUD, they're going to be working towards connecting them with the doorways for a pre-release screening. With the SMI, they're going to be working with the CMHCs to get a pre-screening in there. The individuals have a right to say, I don't want to connect with the doorways, or I don't want to connect with the CMHCs. I want to connect with, my old provider. The MCOs will have to respect those individuals' rights to that. The package, the pre-release package, like I said, does include a pre-screening. The code for the SMI side that we got is a code that's only going to be opened up for the reentry. It's not going to be in the regular state plan because, as you folks well know, we have a very distinct and detailed intake process for you folks to determine eligibility. We're not going to upend that. The code that we're going to use, it's technically called a behavioral health treatment program screening, something like that. It reads much like you're going to screen someone to see if they need ASAM 3.1 level of care, for example, the 3.5 level of care. But the coding specialists have assured the department that it can be used for the mental health population as well. So that will be the service that the CMHCs would be the MCOs would be referring the CMHCs to try to perform. The other one is a peer connection. So they will be able to refer to the CMHCs for a peer connection. The peer support services is only going to get opened for the CMHCs at this time. We're not opening up to other providers under the Medicaid benefit right now. So that's why it'll be the knock on the CMHC door. The closed loop referral will be available in the future for it. They did not want to work on that part right now because of everything else that is necessary to operationalize. But yes, we'll get that session set up.
Okay, and the MCOs, that's certainly a piece of it, but for me, I'm even thinking more about some of the stuff you just said, like what is the tool that we're going to use for this screening? And for me personally, I would hope that all the mental health centers would use the same tool. And so that's where my brain's going with some of this stuff. And again, I could have missed out on stuff. That PowerPoint from last week was very helpful, but I'm just hoping to have more dialogue and get on the same page with folks.
So because it's the reentry, the real intent behind that pre-screening is to get the CMHCs the opportunity to get to know the person a little bit, just so it's kind of like a warm handoff. I know that under the CCBHC model, you folks have like a preliminary screening, but we are not going to point to a particular tool, Chris, for this. I think that you folks have talked about those times when you do end up having like a two-step intake process. It may just be you want to do like their social history a little bit, things like that, a little bit of the intake elements, but not all of it. But we're not going to prescribe what that has to be.
Okay.
Chris, just so you know, I did pose the question to the QI directors, just to see if there might be some opportunity for us to come together across agencies and see if there might be some things that we can think well about, either things that we have in our current systems or something that we can kind of put together that we could collectively, I think approach in a streamlined kind of similar way across all 10 of us. So so that has been posed to the QI folks, and hopefully we'll have some opportunity to share ideas and get together at our next meeting to talk further.
Okay. Yep. That sounds good.
Thank you. And Jen, that would be great. Yeah. So there's something in the chat about future meetings, and I'm meeting with Katya and Julianne on Monday for transitional purposes and handoffs and stuff. Would this cadence still be, in this time slot, still be something the CMHCs want to do? Is it helpful weekly, at least maybe through January, because there's so much moving in January? After that, I don't know. So whatever feedback you want to share, if you want to send it to Carolyn, I think that would be great. Carolyn, that'll be largely up to you and what you want to feed into the discussions with Julianne. Okay. All right. Thank you all. I appreciate all of you, and it's been great.
Thank you, Diana.
Thank you,
Hope to
Diana.
see you on the
Diana.
other side.
Thank you.
Thank
you.
you.
Diana.
Thank you.
Bye.
Thank you, Diana.